Hi, I'm Dr. Michelle Clayman. I'm an emergency physician at St. Michael's Hospital. I also practice addiction medicine at the hospital and a community clinic. Today I'm going to be talking about pain management for patients receiving maintenance therapy for opioid use disorder. I have nothing to disclose. I'd like to acknowledge the two main resources that I base this talk on. The first is the 2017 Canadian Guideline for Opiates for Chronic Non-Cancer Pain. It can be found at this website. In addition, the Physicians for Responsible Opioid Prescribing is a great website if you need more information. This talk has undergone many iterations, and slides have been borrowed and modified from Dr. Cavatuti, Dr. Wasser, and Dr. Boardman. Some abbreviations you might see during this talk is OAST, which stands for Opioid Agonist Substitution Treatment. More commonly, OAT, which is Opioid Agonist Therapy. COT stands for Chronic Opioid Therapy, and UDS is urine drug screens. There are 5 learning objectives from this talk. The first is to identify situations where people on methadone or buprenorphine treatment may require pain control. The second is to describe the options for treating acute and chronic non-cancer pain in clients on methadone or buprenorphine for opioid use disorder. The third objective is to outline monitoring parameters for following clients on methadone or buprenorphine requiring pain control. The fourth objective is to identify healthcare team members who should be informed of any changes in the patient's medication regimen, including new prescriptions for pain control. The final objective is to apply the Canadian Guideline for Safe and Effective Use of Opioids for Chronic Non-Cancer Pain into daily practice. Chronic pain is a very difficult disease to treat. Family physicians rank chronic pain management second only to mental health as a clinically challenging area. This is published in MD Dialogue in 2009. This is due to many reasons. First, the pain is very difficult to treat, and 2, there's always a risk of patients developing a substance use disorder or an opiate use disorder. Pain in and of itself is very difficult to measure. It is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. This definition comes from the American Pain Society. I prefer the second explanation by Margot McCaffrey, which is from 1968. Pain is whatever the experiencing person says it is, existing whenever he or she says it does. It is a personal experience, and we can't say by looking at somebody whether or not they're having pain and their degree of their pain. Well, we don't have a glucometer to measure pain the same way we have a glucometer to measure glucose. We do have some tools to assess the intensity of patients' pain. 3 general ones are the visual analog scale, the numeric rating scale, and the verbal scale. The most common one out of these 3 is numeric rating scale. This is where we ask patients to rate their pain on a scale of 0 to 10, 10 being no pain, and 0 being no pain, and 10 being the worst pain they can imagine ever experiencing in their life. For cognitively impaired patients, there is a FACES scale, the behavioral scale, and the ABBY pain scale. In clinical practice, even though it's important to know the number, how severe somebody's experiencing the pain, what I care about more is the change in the number. So if their pain is initially an 8 out of 10, I'm more concerned about that number going down to a 6 out of 10 or a 5 out of 10, not the number itself. When we think about how to manage pain, we have to accurately assess the pain and then develop a holistic approach that includes non-pharmacological and pharmacological methods for treatment. This is very important. Patients often expect a medication, a magic pill, to take away their pain. This is not a realistic expectation. The medications are only going to take away pain about 30%, so we really do have to focus on the non-pharmacological aspects. We're going to talk about some situations now where people on methadone or buprenorphine treatment may require pain control. We're going to focus on chronic pain because it is much more difficult. However, I do want to mention that acute pain is a very important experience not to ignore. So when a patient is on methadone or buprenorphine, and they have an acutely painful injury, like breaking their ankle or having surgery, they require opiates at a higher dose and often more frequently than somebody who is not on methadone or buprenorphine. This is because they have a very high tolerance to opiates and a very low tolerance to pain. When we think about chronic pain, This is defined as pain that lasts for greater than 6 months, although it may be shorter depending on the mechanism. It is longer than tissue healing or expected resolution. Chronic pain recurs over months or years, and really we're limited in the ability to define the mechanism of many types of pain. So we often cannot find the reason for somebody's pain. We can do all the tests in the world. It doesn't matter. We often cannot find the reason. Treatments, as I mentioned, are not limited to opiates, and treatments are ideally multidisciplinary. So bringing in physiotherapists, chiropractors, massage therapists, etc. The prevalence of chronic pain in Canada is that 1/3 of Canadians have moderate to severe chronic pain. This is a huge number of people in our country, 1/3, so 1 in 3 people. 1 in 5 experience pain daily, and 1 in 6 experience constant pain. Chronic pain is actually more prevalent in our country than diabetes or asthma. The impact of chronic pain is severe. 40% of patients suffer from concurrent anxiety or depression. 30% of patients with chronic pain state that their family does not understand, which can be incredibly isolating and add to depression. 1/3 of people with chronic pain have lost their job, and half have suffered an income loss due to pain, on average about $12,000 per year. Most striking is the risk of suicide. So somebody who has chronic pain is at 2 times the risk of suicide of the general population. During med school, we had Pain Week. And what we learned is that if somebody has pain and we prescribe them an opiate, they're not going to develop an addiction. And somebody who has an addiction to an opiate cannot really have pain. What I learned over time, and I think the med schools are no longer teaching that binary definition of pain and addiction, is that pain and addiction is a continuum. There are patients who can have pure pain and are treated with an opiate and never develop an addiction. There are patients with an addiction who never have any pain, but there's a huge overlap in the patients who have pain and then develop an opiate use disorder. It is really a spectrum. In my office, I have to say that the majority of my patients who developed an opiate use disorder were prescribed an opiate by a well-meaning physician to treat pain. Over time, the dose escalated to the point that the opiates became counterproductive and actually contributed to the pain. And then they developed an addiction or an opiate use disorder as they would go outside the physician office to the streets to buy other opiates, often escalating to intravenous use. What we do see now, though, is an overlapping of all these different entities. So patients can have chronic pain, they can also have an opiate use disorder, and they can also have a lot of complications related to their opiate use. Methadone and buprenorphine come in and can help with all of these things. So they can help with chronic pain, they can help with opioid use disorder, it can help with opioid-related complications, and really methadone and buprenorphine can be very useful to help chronic pain, opioid use disorder, and reduce the number of complications we see from opiate use. When we look at our clinical practice, what we're seeing is that 50% of patients in opioid agonist therapy report chronic pain. In our province, that is approximately 25,000 patients. This is a large number. This data is old, so I'm sure the numbers are higher now. The hard part is not identifying patients with pain issues. Patients who have pain will tell us they are in pain. The hard part, though, is treating these issues safely and effectively. So how do we know who is drug seeking for the purpose of recreational use or selling their medication? And how do we know who we actually need to be prescribing for their opiates to? A very interesting study came out in 2012. What it showed was that drug-seeking patients appear to exhibit classically described drug-seeking behaviors with only low to moderate frequency. So reliance on historical features may be inadequate when trying to assess whether or not a patient is drug-seeking. So we often miss patients who may be, quote-unquote, drug-seeking because they're not distributing these classic drug-seeking behaviors. Therefore, it is recommended that we apply the concept of universal precautions when prescribing opiates. Universal precautions is a theory that is often used in phlebotomy. So when we go to get our blood tests, when we go to get our blood taken at the lab, the nurse or whoever is taking it, the technician, will wear gloves, will also use safety needles because they don't want to poke themselves because they can't tell by looking at us whether or not we have a blood-borne disease. So they protect themselves against needle stick injuries from everybody. It is the same with opiates. So we have to assume that anybody is at risk for developing an opiate use disorder. We have to carefully evaluate patients when prescribing opiates. We have to closely monitor them. We have to use a cautious, structured approach and have clear benefits and outline the benefits for pain and function. Really, opiate should be for a time-limited use. We know that there's little or no evidence of long-term efficacy of opiates beyond 16 weeks. So patients who are on opiates for years, we know that they may not be effective after that time. We have to make sure that we talk to patients about the therapeutic goals, which might include increased activity and improved quality of life. We have to inform patients about the risks of opioids, and this includes constipation, weight gain, suppression of the testosterone axis in males, sedation, risk of addiction, overdose, and death. We have to talk about the rules for safe and appropriate use of opioids, and a written treatment agreement is very important. We are very used to using treatment agreements in patients who are prescribed methadone and buprenorphine, but we should also be using them for patients who are prescribed opiates for chronic non-cancer pain. When patients are started on opiates, we really should be seeing them very often, so 1 to 2 times per week. Prescriptions like methadone or buprenorphine should be short and ideally weekly dispensing. So dispensing 120 tablets of a short-acting or long-acting opiate is not appropriate. Once patients are stable, they should be seen once a month. And really, patients, same with methadone or buprenorphine, should be seen from one doctor for their prescription renewals. If another doctor needs to provide a prescription, it should just be a bridging prescription until the usual doctor returns to the office. We need to have benchmarks for stopping chronic opioid therapy. We have to have a procedure for tapering, because if somebody stops an opiate that they've been on for 4 months, they're going to have withdrawal symptoms. So we have to have an approach to manage physical and psychological withdrawal symptoms once the opiates are stopped. I'm going to talk about some options now for treating acute and chronic non-cancer pain in clients on methadone or buprenorphine for opioid. So what are we actually going to be using? Slide 29. So what are we actually going to be using? So this is a huge topic. There are many adjuncts to opiates. This includes, amongst others, acetaminophen, anticonvulsants, capsaicin, central nervous stimulants, non-steroidal anti-inflammatory drugs, etc. There's so many medications that we can use besides opiates. When we look at the Canadian guidelines for opiates for chronic non-cancer pain, it states that for patients with chronic non-cancer pain with an active substance use disorder, we recommend against the use of opiates. In addition, for patients with chronic non-cancer pain with a history of substance use disorder whose non-opioid therapy has been optimized and who have persistent problematic pain, we suggest continuing non-opioid therapy rather than a trial of opiates. So that's interesting. What they're saying here is that patients with active substance use disorders or a history of a substance use disorder, we really should not be using opiates for these patients. When we think about the non-pharmacological adjuncts, we have to remember how important and how effective a lot of these can be. Unfortunately, in our medical system right now, a lot of these non-pharmacological adjuncts are not covered by most government-supported healthcare plans. If our patients have private medical insurance, they will be able to obtain some money for physiotherapy and chiropractors. But we have to remember that heat and cold are very important. Reiki, massage, distraction, mindfulness, physiotherapy, transcutaneous electrical nerve stimulation, chiropractic manipulation, relaxation, imagery, exercise, yoga, aromatherapy, acupuncture, tai chi, hypnosis, the list goes on and on. So we have to remember that even though we are prescribing our patients medications, and that's what we do as pharmacists and physicians, we have to remember that there are so many options for non-pharmacological adjuncts to help with pain. A clinical pearl here is that anything that works in patients who are not on methadone or buprenorphine can also work on patients who are on methadone and buprenorphine. So treatment that never worked before they were on methadone or buprenorphine can often work once they are on agonist treatment. I'm going to talk to you about an experiment that has been done and repeated several times. This experiment shows that patients who are on chronic opioids have a very low tolerance to pain and a very high tolerance to an opioid. The study involved taking two groups, one group who is not on opiates and one group who is on chronic opiates, and asking them to put their hand inside an ice-cold bucket and keep it there for as long as they possibly could. Both groups were either given an opiate or not getting an opiate, in addition to the opiate that they may have had that day. So if we look at the top left-hand quarter, this is the patients, these are the subjects that were not on chronic opiate therapy who was given an opioid that morning before putting their hand into the bucket. What they found is that these people were able to keep their hand in the bucket for 4 minutes. Just below that is the same group of people or subjects that were not on chronic opioid therapy who were not given an opioid prior to the ice-cold bucket test. What they found is that these people were only able to hold their hand in a bucket for 3+ stars or 3 minutes. That makes sense, right? Somebody who's not normally on opiates is given a painkiller before they put their hand in an ice-cold bucket. They can keep their hand in the bucket for much longer because they can withstand the pain. If they're not given an opiate before they put their hand in the ice-cold bucket, they can only hold their hand in the bucket for slightly less amount of time. Compare that to the right-hand side. So this is a group of people who are on chronic opioids who had their usual opioid that day. Half of them were given an opioid prior to the ice bucket test, and what they found was striking. They were only able to hold their hand in the bucket for 2+ stars or 2 minutes. And I'm going to talk to you about an experiment that has been done and repeated several times. This experiment shows that patients who are on chronic opioids have a very low tolerance to pain and a very high tolerance to an opioid. The study involved taking two groups, one group who is not on opiates and one group who is on chronic opiates, and asking them to put their hand inside an ice-cold bucket and keep it there for as long as they possibly could. Both groups were either given an opiate or not getting an opiate, in addition to the opiate that they may have had that day. So if we look at the top left-hand quarter, this is the patients, these are the subjects that were not on chronic opiate therapy who was given an opioid that morning before putting their hand into the bucket. What they found is that these people were able to keep their hand in the bucket for 4 minutes. Just below that is the same group of people or subjects that were not on chronic opioid therapy who were not given an opioid prior to the ice-cold bucket test. What they found is that these people were only able to hold their hand in a bucket for 3+ stars or 3 minutes. That makes sense, right? Somebody who's not normally on opiates is given a painkiller before they put their hand in an ice-cold bucket. They can keep their hand in the bucket for much longer because they can withstand the pain. If they're not given an opiate before they put their hand in the ice-cold bucket, they can only hold their hand in the bucket for slightly less amount of time. Compare that to the right-hand side. So this is a group of people who are on chronic opioids who had their usual opioid that day. Half of them were given an opioid prior to the ice bucket test, and what they found was striking. They were only able to hold their hand in the bucket for 2+ stars or 2 minutes. That's even less than the group who are not on opiates who are not getting an opioid that day. Those who are on chronic opiates who are not given an opioid that day were only able to hold their hand in the bucket for 1+ stars or 1 minute. So key points from this study is that chronic opioid users have a lower pain tolerance than non-opioid users, even when given their regular dose of medication. This is a phenomenon called opioid-induced hyperalgesia. This happens more with short-acting, high-potency opiates. Another theory to explain this is a gate theory. When somebody is exposed to pain at the nerve ending, this pain is transmitted through a pain signal to the pain gate. The gate opens and the brain experiences pain. The brain then exhibits inhibition and closes this gate, and then less pain is experienced. What happens when somebody is given an opiate? Another theory to explain this is a gate theory. When somebody is exposed to pain at the nerve ending, this pain is transmitted through a pain signal to the pain gate. The gate opens and the brain experiences pain. The brain then exhibits inhibition and closes this gate, and then less pain is experienced. What happens when somebody is given an opiate is that the opioid acts at the level of the brain. The pain comes in through the nerve ending, opens the gate, and then the brain is going to feel pain. However, the opioid who's acting at the brain then adds to that CNS inhibition and closes the gate. So the brain feels less, or in some cases, no pain. However, with chronic opioid therapy, what we see is a process of neuroadaptation. So the same pain is being experienced at the nerve ending. This pain signal is sent up to the gate. However, at the level of the brain, the opioid is not working as well. So the ability of the opioid to treat pain is much smaller. The patient has developed tolerance. In addition, the brain's natural ability to inhibit the pain signals is also reduced. So the gate reopens and the brain starts feeling more pain. This is a phenomenon through neuroadaptation called opioid-induced hyperalgesia. This process of neuroadaptation happens when the opioid levels are the highest. So if somebody is taking an opioid 3 times a day, so a high potency, short acting opiate, it is at those peaks when levels are the highest where we see this change in the brain, the change at the receptors called neuroadaptation. What ends up happening is that the opiates don't end up binding as well to the receptors. The opioids, in addition, don't work as well once they're bound. And any fluctuations of that level of opiate in the system is going to cause pain. It's going to cause withdrawal, and it's going to cause pain. So what ends up happening? So the dose has to keep going up and up and up so that patients can have, due to their tolerance, they can experience some pain relief as they increase the dose. However, what ends up happening is now the pain line has moved up above the therapeutic window, and what we're reaching is the line for overdose and intoxication. So the higher the dose of opiates, the more risk of opioid overdose and death. What switching to methadone or buprenorphine does when somebody who's on opiate therapy for chronic pain is it simply provides a very long-acting opiate in the system. So you're not getting these constant fluctuations throughout the day. So therefore, neuroadaptation doesn't occur. And actually, if somebody's being switched from an opiate to methadone or buprenorphine, the neuroadaptation can begin to normalize again. So the receptors reset, and over time, approximately 6 months, the neuroadaptation can reverse. So just to be very clear about what opioid-induced hyperalgesia is that opioid-dependent individuals can have pain at high blood levels of opiates. And this is because their level of neuroadaptation is so severe that any small drop in the blood opiate level causes aberrant nerve firing that results in pain. So not only are the opiates not working, but the receptors are also firing aberrantly. So the patient's experiencing severe pain. And we treat this by starting buprenorphine or methadone, long-acting opiates. It allows the neuroadaptive changes to revert back to normal and reduces the risk of aberrant nerve firing that results in pain. There's nothing magical about methadone or buprenorphine. They're simply very long-acting opiates, so they can be very helpful in the treatment of chronic pain. The studies looking at outcomes in patients on opiates are clear. It is really the program that is more important than the medication used. So what does the program look like when somebody goes into a clinic? Are there case managers? Are there social workers? Is there a psychologist or counselor that they can see? All of that is much more important than the actual medication that they're prescribed. So yes, methadone and buprenorphine are longer acting, and that's why they're very effective. But it's also their frequent contact with their pharmacist and their physician that can be useful. So supervised daily ingestion in the pharmacy. And then, of course, the contingency management. So the allowance of carries with time as patients are doing well. Relapse leads to tighter boundaries, so fewer take-home doses and more frequent visits. Next, I'm going to discuss how we monitor patients who are on methadone or buprenorphine requiring pain control. When patients come into the office, we must ask them about the 4 A's. So, are they getting adequate analgesia? Are they able to function in their daily activities, and how's their quality of life? Any concerns around aberrant behavior and any adverse effects from the opiates. Again, relying solely on aberrant behaviors to diagnose opiate misuse and addiction will miss more than 50% of problematic users. So it's really important to get an accurate picture of past and current drug use, if possible. Patients are often reluctant to disclose a history of substance use. We can, however, get some information from when patients come into the office, we must ask them about the 4 A's. So, are they getting adequate analgesia? Are they able to function in their daily activities, and how's their quality of life? Any concerns around aberrant behavior and any adverse effects from the opiates. Again, relying solely on aberrant behaviors to diagnose opiate misuse and addiction will miss more than 50% of problematic users. So it's really important to get an accurate picture of past and current drug use, if possible. Patients are often reluctant to disclose a history of substance use. We can, however, get some information from old medical records. We can take a look at the drug profile viewer used in the narcotic monitoring system. We can consult third parties as needed, complete the opioid risk tool. And then one tool that we use a lot is a urine drug screen. This is often used in methadone, this is always used, I should say, in methadone and buprenorphine clinics. However, I think that we should be using it more frequently in patients on chronic opioid therapy as well. Some patients might find it a bit off-putting to do urine drug screens. However, there are ways to talk to patients so that they don't get upset. We can tell them that chronic opioid therapy always has a lot of risk for patients or families in the community, so we have to be vigilant. We have to tell patients that we're not doing the urine drug screens because we don't think they're dishonest. We just want to protect them and comply with best practice. Obviously, we have to know how to interpret the test result, and we also have to act on the test result. What we do in the office is we use a 5-panel DIP, which contains the medications they're prescribed and other substances of abuse. This is to ensure that they're taking their medication as prescribed and that they're not using other substances. If they are using up other substances, this would result in a loss of their carries. There's an excellent overview you can access free of charge called the Urine Drug Testing Clinical Practice. The link is at the top of the slide. When we ask patients for urine drug screens, they should be providing it on the day that it is asked for. If they cannot leave a sample, we often will leave a prescription at the lab or the pharmacy and ask them to come back later the same day. Sometimes we ask our pharmacist not to dispense the prescription until they've confirmed that the urine drug screen is done, and we can always interpret it at a later time. When patients come into the office and they have a positive urine drug screen but have not disclosed. When we ask patients for urine drug screens, they should be providing it on the day that it is asked for. If they cannot leave a sample, we often will leave a prescription at the lab or the pharmacy and ask them to come back later the same day. Sometimes we ask our pharmacist not to dispense the prescription until they've confirmed that the urine drug screen is done, and we can always interpret it at a later time. When patients come into the office and they have a positive urine drug screen but have not disclosed they've used other substances, this is the way I often phrase the conversation. The result of your urine drug screen is not consistent with the history you've given me. In order for me to safely prescribe these medications, I need my patients to be open and honest with me. I'd like to give you this opportunity to tell me what is really going on. Now we're going to talk about your role in chronic opioid management. So pharmacists play a very important role for patients on methadone or buprenorphine and chronic opiate therapy. You have daily contact with the clients and can develop a rapport with them. You also see them much more frequently. So if patients are not doing well, you can notify the physician. They see me once a week. They can get it. If they're not doing well, they can get it together for one day, but they can't necessarily get it together for the remaining 6 of the week. So collaboration with the physician is very important because you can provide crucial information about the patient based on your experience with the individual. The pharmacies that I use have my personal cell phone number, as well as my fax number and email, so they can contact me when needed if there are issues around the patients. This has provided amazing patient care, and a lot of things would have gone missed had I not been received information from pharmacies. With regards to your role with methadone, buprenorphine, and chronic opioid therapy, you dispense and provide education and counseling about the safety and security of all medications, and you properly administer the dose. You co-consult with physicians to optimally manage patients. And please let us know when there's been any interruptions in dosing, so any missed doses. You're the gatekeepers. You can decline to fill inappropriate prescriptions and educate pharmacy staff to be non-judgmental. I really think pharmacists do see the big picture. So what you're seeing here in the bottom left-hand corner is a bunch of doctors with blinders on touching an elephant. They all think they're touching something else. One thinks they're touching a brick wall. The other one thinks he's touching a rope. One thinks they're touching a sphere. And then you have the pharmacist seeing the big picture, wondering, I wonder if all these doctors know if that is an elephant. So throughout this talk, I hope that I've applied the Canadian Guideline for Safe and Effective Use of Opioids for Chronic Non-Cancer Pain, slide 59. This resource, again, is open access, available online at this website. Some key recommendations out of this document are that patients with chronic non-cancer pain with an active substance use disorder, it is not recommended that we use opiates, and this is a strong recommendation. And for patients with chronic non-cancer pain with a history of substance use disorder whose non-opioid therapy has been optimized and who have persistent problematic pain, we suggest continuing non-opioid therapy rather than a trial of opiates. Again, this is a written recommendation. Please refer to the guidelines should you have any further questions around this. Thank you very much. This is my email address should you have any further questions.